Hello, guys. Hello. Can you hear me? Yeah, that looks great. Hello, good afternoon, and welcome to the FHIR DevDays virtual. Um, Welcome to this special times, and welcome to my home. As you can see, I'm not even going to pretend I'm with you. I am here in Amsterdam. It's 7 o'clock in the evening, and I'm sitting in the room where I've been for the past 3 months working and preparing for these DevDays. So, let me get on my bike, because in the end we'll have to work. It's just right here. This is where I work. Oh, let's see if I can put you on a closer camera here. Yep, there we go. So welcome again. This is my house. Tomorrow, the day after tomorrow, I'm going to show you a little bit of my place, just to show that there are actually faces behind this meeting. There are actual people watching with us, watching with you, even though you might feel alone now and then. So let's get to the slide deck. Here we are. As I said, my name is Ewout Kramer. I'm CTO with FHIR, and we are organizing this meeting together with HL7. So normally, it would look a little bit more like this. These are images actually from a previous DevDays. We're here now with, believe it or not, 700 participants over 26 countries watching over the next 4 days, all in their own homes, from their own homes, before their own screens. And but actually, you have to imagine we're here with the whole community, and I hope we can still give you a sense of this community feeling. Do remember that most of the time, about half of the participants are new, so don't hesitate to ask questions. We got all the facilities for that. So before we start this meeting, I'll just go through a few practicalities, because I remember from my first virtual meetings that after the main session, and it was like, what do I do now? So I hope to avoid that, and let's run over the program. So the first 50 minutes, you don't have to do anything. Just sit back and relax. It's the general session. So for the next 50 minutes till about, well, it would be about 8 o'clock my time, but it's about 2 o'clock Eastern. And we'll have these speakers, but I'll introduce them one by one. After that, though, you'll risk the fear of missing out, because we'll have blocks with parallel sessions. So we'll have 4 blocks with 4 or 5 sessions each. Of course, everything is recorded, so you'll be able to watch them pretty soon afterwards. And this is on a 40-minute rhythm, so each session is 40 minutes. And there's an exception, though. There's a community track, and the community track is actually a track that has speakers each 15 minutes, runs the whole day. And those are people that want to share with you their actual experiences with implementing FHIR. The sessions in the general track are more tutorial-like. Well, you probably have checked them out a little bit in your agenda. So there's the community track, very interesting stories from the battleground. And many of the sessions you'll see today and tomorrow actually have twin sessions that's called Let's Build. So in the first days, you'll have a session with the theory to learn something, and then the next days, you can actually apply what you've learned in the Let's Build section. So check for that in your agenda. Each day is closed by Wayne Kubick, who we'll be seeing momentarily. And that's a wrap-up. Tonight, after the wrap-up, you can do whatever you want, read your emails. But tomorrow, we'll actually have a pub crawl, but more on that later. So a few practical things for during the sessions. Well, you must imagine, we all go virtual now, but we're starting to get used to it, but you can see software is just getting to grips with it. So we have to figure out a way so you could communicate with us and the speakers during the sessions. So the way to do that is to post your questions in the Whova Q&A app. So you'll be running, obviously you're looking at the Whova app right now, either mobile or on desktop. And there is a Q&A session. In the desktop, it looks like this. There's a session Q&A. And there's also a chat tab next to it. Don't use that one, except to refresh the session Q&A. We've noticed the desktop app can lag a little bit with the questions and answers. So if you change between chat and session Q&A, it will refresh, and you'll see the latest in the session Q&A. Don't use the Zoom chat Q&A functionality. There is a way to get to it, but we're not watching it, and please use the Whova Q&A. The speakers will be helped by moderators who watch this Q&A all the time, even after the session. And so you can ask questions there, and if appropriate, those moderators looking at those questions will forward the questions to the speakers. And we will be recording, and we'll try to make the sessions available as soon as possible after a session ends. If you're not at a session, at any time, there's still a lot of things you can do. You can still post questions to the Q&A. So each session has its own Q&A, and the answers and questions will remain there. You can even ask a few more if you want. You can send a message to the speaker. So every session has a sent message. And so you can use that to contact the speaker directly. And what you also can do is schedule your own meetup through Whova. It's here. Oh, sorry. There is you have to press community, and then in community there is meetups and virtual meets. You see I displaced my image, so the arrow doesn't really work anymore. But the meetups and virtual meets, you can actually organize your own meetups and have a session about whatever subject. Those who've been to DevDays before know that we always have these little sessions left and right, unplanned ad hoc sessions. Feel free to organize your own meetups while this meeting lasts. Separate from that, there is a whole team. If you've been at DevDays before, you'll notice they always wear these yellow shirts like I have here, and they're walking around to help you. Don't worry, they are still there, and they're watching the Ask Organizers Anything channel. Actually, they're watching everything. So if you have questions about logistics, the app, or whatever, you can always ask in that channel, and they'll be around to help you with that. That's almost it, actually. I would say take advantage of being virtual in the sense that there are no queues for drinks and food. You can drink your own food. You can go to your fridge, whatever you want. So that's good. Another bit advantage might be that you can skip to other sessions easily without even others seeing that you're leaving the room. So take advantage of that as well. There's some disadvantages too, of course. For those who've been with us before, we normally have the chair massage. We don't have those, though we do have yoga sessions. And of course, maybe the biggest disadvantage of all, you don't get to drink a drink with James. But the good news is we have tried to figure out a alternative, which are the virtual pubs. So if you go in the agenda for tomorrow night, you'll find the program for the virtual pubs. And maybe important for today is that some of these pubs ask you if you want to participate fully to shop some goodies to eat and drink with us while enjoying the virtual pub. There's a taste along shopping list at the bottom there that you could use for that. So finally, a slide with the logos of our sponsors who've made it possible that even in these times we can continue doing DevDays. And again, this meeting is brought to you by FHIR and HL7. This being our first big meeting that we do, we hope, of course, that everything will run well. And a thanks to our host sponsor, Microsoft. Well then, next up, another guy on a bicycle. I'm talking about Wayne Kubick, the CTO of HL7, and he is going to take it from here. Off you go.
Thank you, Ewout. And for those of you who don't know, if Graham is the father of FHIR, Ewout's the father of FHIR DevDays. So this is number 8, I think. I think I got that number wrong. I think 3 or 4 months ago, we thought we'd all be sitting in a dingy hotel basement in Cleveland. And instead, here we are in the comfort of our own homes, having the opportunity to work together in a different way. We'll have to try a little harder this time to interact. And we spent a lot of time trying to figure out the best way to do it, but it is our first time. So be patient as we explore new things as things happen. We think we've got a great show for you. And in addition to thanking our sponsors, on behalf of HL7 International, I'd like to thank our speakers. I'd like to thank you, our attendees, who have to juggle your daytime jobs while attending a meeting like this. And I'd like to thank the HL7 FHIR team, who's really been working hard to make this an event that you will remember. In addition, as my role as CTO, which is Chief Thirst Officer of HL7, I've been pretty focused on the virtual pub, and so I hope most of you will be able to join us tomorrow. But finally, let me just say a formal welcome and thank you to the best event of the year, my favorite event, FHIR DevDays. So, to kick things off formally, we're opening up with Dr. Don Rucker. Normally, I usually give my own introductions, but this time I have to actually read one because there's so much to cover and it's too many words for my memory to hold at one time. Dr. Rucker has been a champion, true champion of health interoperability, of the use of APIs, and the use of FHIR, and he's been an incredible supporter of HL7. We wouldn't be where we are without him. But his official title, he is the National Coordinator for Health Information Technology at the U.S. Department of Health and Human Services Office of the National Coordinator for Health IT. Whew, a little redundant. Where he leads the government's development of federal health IT strategy and coordinates policies, standards, programs, and investments for the entire health IT ecosystem. Our health IT world has never been more complex and more active than it is today. Dr. Rucker's experience in healthcare and informatics is as long as his current title and office name, which is the longest one I've ever heard, starting with his time historically at Data Meta Corporation, where he actually co-designed the first Microsoft Windows-based EHR system. He was also clinical professor of emergency medicine and biomedical informatics at The Ohio State University, and was chief medical officer at Premise Health, which is a worksite clinic. He graduated from Harvard College and the University of Pennsylvania School of Medicine, and is board certified in emergency medicine, internal medicine, and clinical informatics. Always the underachiever, he also found time to get an MBA and Master of Medical Computer Sciences, both from Stanford. So, with no further ado, thanks and welcome to Dr. Rucker.
Wayne, thanks. This is an awesome event. Just an absolute pleasure to be here. I admired the coordination and everybody high-fiving. I was trying to think, let's say, would that be the right or the left? And of course, I love Graham's take on public health activities with his flammable liquids there. So exciting times. It is always great, I think, when you're doing something that has the momentum of history and economics going for it. And that is exactly where we are today with FHIR. The US Congress passed in 2016 an act called the 21st Century Cures Act, almost unanimously, interesting enough. A lot of that had to do with Food and Drug Administration development, but a large chunk of it was also on interoperability. And while some of these things are uniquely out of the issues with the American healthcare system, I believe the benefits are really going to be for literally everybody on the planet. And you know, the benefits will be very international. So what did Congress, this was a law then signed by, just for historical context for folks, signed by President Obama in 2016, heavily supported by President Trump, Secretary Azar, Administrator Verma, and the current administration. So what is in that law? What do we have there? Well, Congress did a little bit of diagnostic work and realized there were a couple interoperability issues that they could help out with. The first really is the concept that information for patient care should be shared, that this was not to be hidden. And Congress and the law terms a concept called information blocking. And what this is now made illegal. And then the second part is having APIs, application programming interfaces. Obviously, everybody in this call knows that cold, but just in case somebody doesn't. And what is different about those APIs and what gets to the heart of today's events, this week's events, are that those APIs should be without special effort, right? So that means standards. So what does that mean? Well, that is what we're here to talk about. So building and enhancing those standards. So those are critical things. The way things work in the United States is Congress passes the laws, and then federal agencies in the executive branch write rules to administer them. And we have just posted our big interoperability rule that puts in place what exactly information blocking is and isn't, and more importantly, directs the world to FHIR APIs, using initially the US core data for interoperability, so a data set with medications, allergies, problem lists, clinical notes, and that will be expanded over time. It is a living, breathing document that I think gets at the heart of the opportunity with the FHIR community. So those are the two core things that are now law. The way that the API part of it works is ONC, that's the short title for the long office name that Wayne read out. ONC comes in and has rules on certifying electronic health records with these APIs, and then the Center for Medicare and Medicaid Services, CMS, our literally trillion-dollar health payment agency, comes up with rules to require those APIs and those EHRs. So that's how we work things, and we're obviously very excited in the opportunities in FHIR. The modern RESTful JSON FHIR API is something that is, I think, going to be very bountiful for the healthcare community, for opening it up to lots of developers, lots of imagination, lots of creativity. If you go into the rule, if you look at healthit.gov on our website, you will see all kinds of webinars, slide decks, so you can get yourself familiarized with those things. If you wish, we have a number of resources on our website. So we have the interoperability proving ground, where I believe there are right around 100 different COVID projects that folks have submitted for looking at it. We would definitely like to thank the FHIR community for the US core, the implementation guide work, for the smart app launcher and all of the work there to make this real. Another area that we're very excited about is what we call population level FHIR bulk data. Originally, bulk was just a tracking term that Ken Mandel and I came up with, Boston Children's, but everybody seems to have glommed onto it. And what is that? That is in HL7 version 4. It is a standard over a population within an electronic health record to have an API. So the APIs are not just an individual query about one patient, but in this case, over a population. Each country will have its privacy rules. In the US, that comes under some classic HIPAA privacy rules or treatment payment operations. The other parts, the individual access for the app economy, comes under the HIPAA right of access. Again, our vision is in the US and in the world that patients can get their entire medical record on their smartphone, take it with them, be in personal control of that record, and have a build out of vast human creativity around the patient's medical data. I've heard that there are 200,000 healthcare apps in the app stores. I don't know, but I do know that almost none of them have access to patient level data. And if we're going to have better fitness apps, as you see, there's seems to be a predilection for biking here, and I would have been on my bike, had a little bit more advanced planning. It's right next door in the other room. But we want these apps to be informed by the patient's medical record and to be as rich as possible, as empowering as possible, and have the patient, wherever they are in the world, certainly, obviously for US patients in particular, where the economic issues are large, to be empowered with that information, that is really the goal. This group is at the absolute heart of creating the APIs, the tools, the insights, the protocols to do that. So on behalf of, I think, everybody interested in health, thank you very much. We're at ONC have obviously tried to build out tools to be supportive. We have worked with MITRE on the Inferno testing app for HL7 FHIR things. So you can look on our website for that. That gives you a great way to just see if what you're building works. We welcome, we're building out a community version of that, so we welcome work there. We obviously see the standards as really the starting point for even more growth. We have for US folks a standards version advancement process outlined in our rule to try to move standards along, incorporate the most rapid, accepted standard. Some of that has some very interesting legal challenges in the US regulatory environment that we can talk about more if folks want. And finally, we have a number of ONC colleagues on various sessions here, and we at ONC absolutely welcome your reaching out to us. You can reach us through healthit.gov, and if all else fails, you can reach me personally at donald.rucker, R-U-C-K-E-R, at hhs.gov. So we're very excited about the world. We're very excited about DevDays. I blocked off a lot of time. Hope to listen to a number of the sessions. Want to thank HL7. Want to thank all of the volunteers, Ewout and Wayne, and turn it back over to Wayne. Thank you.
Well, thanks, thanks Don for this intro, this interesting talk. I sometimes wish that I think the US has really taken the lead here, actually, compared to where we stand here at the other side. Next up is Dave deBronkart, and well, as many people I think know Dave, but I'll introduce him just a little bit. He's also called e-patient Dave, and Dave was a survivor of kidney cancer, and while he was ill, he discovered that his data would be powerful to help actually in his process of fighting his disease, but he couldn't get to his data or do the things he wanted with his data. So being used to be a disruptor in the printing industry before, he wanted to do the same thing in healthcare. So we've asked Dave to help us out with our patient innovator track, where the patient is central. And well, actually, without much further ado, I'd like to give the word to Dave.
Is this thing working? Yes, wonderful. I'll tell you, this is the mixture of technology here. I know there's been a lot of back chatter about Whova, Zoom, what the heck. It feels very much like in the early 1950s when we were first trying to launch missiles and they would often explode, but except we're leaping right ahead to where we're sitting on top of the rocket. And so I get to be the first one who's going to be sharing slides, I think. And so let's see. I think I'm going to try sharing my PowerPoint, but where do I do that? I can, the usual Zoom share screen button is here. And you're just going to have to interrupt me if anything is not working, okay? And I hope that my audio will go along with it as well. Go back to slide 1. Here we are. Okay, well, welcome to the Patient Innovator track. I'm going to give you a little bit of orientation to it, and then we will dive into our first presenter. Let's see if this works. One for the doctor, a 2 for the nurse. You say you're trying to treat me, so it make me feel worse. Give me my damn data. Give me my damn data. Give me my damn data. It's all about me, so it's mine. Now, that song was created by one of our judges for the patient track, the famous Dr. Ross Martin. And the theme there, the data about me. When I had trouble getting my data in 2009, in frustration, I said, give me my damn data. And Ross changed it from damn to data about me, which really makes the point. Ladies and gentlemen, we are at a point of immense cultural change. In 1871, the early physician Oliver Wendell Holmes, the father of the Supreme Court justice who would become famous in another field, said this magnificent statement: your patient has no more right to all the truth you know than he has to all the medicine in your saddlebags. He should get only as much as is good for him. Well, that's one way of looking at things. In contrast to that, a senior physician at my hospital, who I know many of you are familiar with, Dr. Warner Slack, who died a couple of years ago, said patients are the most underused resource in healthcare. What we are about is one of the factors that is a pivotal difference between being just a crash test dummy in the doctor's office who does what we're told and somebody who can actually make a difference. I liken this. I have come to look at this moment partly because of what Dr. Rucker has helped put together. We have approached a great river. This is a painting of Lewis and Clark, the 1800s pioneers crossing a river out west. They have come to one side of the river. What you can't see here in this metaphor, so this is like patients trying to find the new world. On the other side of the river is the people with that new world, the holders of the data. And we are, with great effort, beginning to cross and make a connection. I'll continue this in a moment. 2 years ago, Michael Morris presented at the Applications Roundtable in Washington, D.C. He was dying of stage 4 cancer, and he talked about how difficult it was that he had data at 4 different hospitals, and none of the doctors had the ability to see the whole picture. Being a developer, he put together a dashboard, pulling together that data, using OneUp Health as the platform to pull together the data. This is, in the history of innovation, we have an early stage where the early adopters will take an 85% solution or less, and they will do the additional work. That's Mike Morris, putting his data together using FHIR. Last year in Amsterdam, we heard from Kate and Christina Sheridan. Kate was this star athlete, football player, and academic who was completely disabled by the world's worst case of Lyme disease. 30 doctors, 15 diagnoses, went from star student to unable to read a single page. Her mother, working for MITRE Corporation, is accustomed to plowing through piles of data. You see there at the top left, that's a stack of printouts of PDFs the different doctors had given her. All right, and that she, at their wits' end, she and her husband typed all of that into spreadsheets, getting it back into data form so they could do their own analytics. And ultimately, at HIMSS 2 years ago, so this is that disabled girl now who is about to graduate from Oxford as a graduate student, completely cured due to insights that were developed from analyzing that data. Please, ladies and gentlemen, you are the keepers of that data that will enable previously helpless people to become contributors in the most awkward situations. Kate pointed out that with all the rising costs and poor outcomes we have in healthcare, yet only 1% of healthcare venture capital is spent on helping people manage their own health. This is what Dr. Rucker is talking about. Then at DevDays 1 year ago yesterday in Seattle, Dana Lewis, the famous open APS of the artificial pancreas patient, described how when the diabetes community decided that they wanted to take matters into their own hands, and they've created open source software to manage their own insulin supply. Last year, DevDays decided to have the first patient innovator track, and John Keyes a developer outside Boston who has created his own app called Blood Numbers to manage his particular condition, right, was the winner. The judging panel. We're going to have one presentation today in a few minutes, a second presentation tomorrow, and then two more finalists on Wednesday. And then on Wednesday night, the judges will vote. That's not the end of it, though. So we have, of course, Graham, Virginia Lorenzi, one of the most stalwart members of the FHIR community. I'm the supernumerary, I'm not judging. But then Ross Martin, creator of that magnificent song, Give Me My Damn Data, is the final judge. Here are your 2020 DevDays US finalists. First, Morgan Gleason, speaking in a few minutes. She is 22 years old today, but back in 2014, she was hospitalized and she gave this magnificent, her mother pulled out her iPhone and just recorded this girl ranting from her hospital bed about how the care she was getting was not patient-centered. She is so compelling, really remarkable. Tomorrow, we'll hear from Olivier Karasira in Rwanda, and he's working on a remarkable project where they're taking citizens' paper health records. And interestingly, as you'll hear, this project started from a desire to help kids do better in school. It turns out they can't do that without health. So they're taking this paper records and converting them into FHIR and SNOMED CT. On Wednesday, Bray Patrick Lake, an amazing woman, a former police officer who's a researcher. She's got multiple conditions, former co-chair of the Precision Medicine Initiative, and yet none of her doctors has a complete record. She wants a unified record. Last December, after a car accident, she actually turned down ambulance transit to an emergency room because she knew they wouldn't have the right information. And you know, if somebody like this can't get their information organized, what chance do the rest of us have? And the title of her talk is She's Entering to Shine a Light into the Void that you will transform. And then immediately following her will be Hamza Salem, who lives in Russia, and he created a diabetes tracker system, which he now has turned into a prototype app. Ladies and gentlemen, these are the early adopters, the people who are saying, I can see the other side of that river. I want to help get there. We are in the early days where right now we're just taking little individual rafts across, but we will build an infrastructure, going from fording a river to having, at some point in the foreseeable future, the completed infrastructure for superhighways that help people get to where they want to be with infinitely less friction. One final item. For the first time in this patient track, in addition to the judges saying what they want, you will have a chance on Thursday to vote with no rules for whichever presentation you liked. The pure People's Choice Award, and the winner of that will get a $35 gift card toward FHIR gear in the HL7 store. And in case you weren't aware that there is FHIR gear, here's a friendly URL for it, to short link to go there. And I forgot to mention, the first prize winner among these four finalists will get a $2,500 cash prize from an unnamed anonymous sponsor. And I think that's just a wonderful thing. The context for all of this, just to bring it to a conclusion and get on with the show, empowerment. People talk about empowerment. It's a warm, fuzzy, feel-good concept. It has a concrete meaning, though. It's increasing the capacity of individuals or groups to make choices and take effective action. That's the World Bank's definition of empowerment. The first law of patient empowerment is, we perform better when we're informed better. The corollary is, it's perverse to keep us in the dark and then call us ignorant. All right? Give us the data, let us help save our own sorry butts. Data about me. William Osler, the founder of modern medical education, said, listen to the patient. So here we are, and I am now going to switch over and play Morgan's. Because of bandwidth issues, we required that everybody record their talk and send it in, and then Morgan will be live to answer a question from the judges. So here we go. Okay, let's see. Oh, aha, they're going to play it, I'm not.
The first experience I have with healthcare that I remember is the doctor crying while she gave my mom the diagnosis of a long, scary word that I didn't understand. My mom was visibly upset, and I heard the words life-threatening. The doctor seemed to have completely forgotten that I, the scared and confused 11-year-old patient, was in the room at all as she delivered this life-altering news. I remember sitting there patiently waiting for someone to reassure me that I was going to be okay, but that moment never came. This is the first time that I realized that the healthcare system wasn't actually centered on the patient. Before this moment, my only experience of being a patient was for pretty quick and simple things. I had been to the doctor a lot over the prior year and a half, but at the time, it all seemed like unrelated problems. I broke a couple of bones and had casts put on. I went to the doctor a lot for different problems, and they asked a lot of questions that mainly my mom answered. I had strep throat a few times and took antibiotics. I had a lot of stomach aches and headaches. At this time, I was a competitive gymnast, and over the next year, I lost all of my tumbling skills. And eventually, it got to the point that I couldn't walk up the stairs or stand up off the floor on my own. I began taking naps all the time, which was really odd behavior for me, and I didn't even have enough energy to hang out with my friends. Even at this young age, I knew something was wrong, but I couldn't put it into words to help my parents or my doctors understand. A rash on my elbows, knuckles, knees, and ankles is actually what led me to the day that I was diagnosed. My doctor sent me to a dermatologist who took small biopsies of my knee and elbow. At the time, I thought that was some pretty serious stuff, but little did I know it was going to get a whole lot worse. A week later, I was in the room when the doctor tearfully told my mom that I had a rare life-threatening autoimmune disease called juvenile dermatomyositis. It is a vascular disease that causes all of the issues I had been having and more. Some of the main symptoms of my disease are muscle weakness, joint pain, severe fatigue, rashes on all my joints, as well as GI, heart, and lung problems. Getting my diagnosis was just the beginning of my experience with a lot of doctor's office visits, hospital stays, and many other treatments. Because of my disease, I take 21 pills a day, get admitted to the hospital once a month for 2 infusions, and I see 12 different doctors in 4 different states. Being a patient can literally become a full-time job. It is absolutely exhausting. Imagine trying to keep all 12 of these doctors on the same page. It is incredibly challenging to have to be the one to mediate between them, since at every single visit, they are always in a hurry or they're rushed. And on top of that, the majority of the time, I'm not feeling well. One of my least favorite things to do at every appointment is having to summarize my whole medical history onto a couple of papers that are attached to a clipboard. When I was first diagnosed, I had to fill out endless questionnaires and answer many of the same questions over and over again. When you take 21 pills a day, it is not fun to write those out every single time. I especially love it when they only provide you with a tiny line to write your medications on, like I can really fit all 21 of my medications onto a single line. Also with these visits, I get asked a lot about what has happened since my last visits, and I am constantly repeating the same exact information in multiple different ways. Because all of my records from every doctor are stored in completely isolated electronic medical record systems, the burden falls on me, the patient, to make sure that everyone is up to date on what is going on with my health. If my doctors don't have the necessary information they need, it can cause me to have to leave without answers, which also means that I have to come back once they are finally sent the information. Occasionally, the lack of necessary treatment or the necessary information causes them to make a different treatment decision than they normally would have if they had had it originally. On top of that, I have found the doctors and nurses searching for this information while I'm sitting in their office causes the scheduled appointment time to be completely wasted. and it can be completely distracting to find the time to discuss the reason why I'm actually there. In general, I have found that if I don't come in with specific questions and goals that I want to get out of the visit, I generally leave frustrated and I don't end up getting the help that I need. In order to have the information I need for myself and to share with my doctors, I have to spend a lot of my time filling out record request forms to each doctor after all of my visits. After I fill out these forms, they send me copies, and I always ask for them to be emailed to me, but they rarely follow my instructions despite it being allowed under HIPAA. They usually end up faxing them or mailing them to me. I have found that doctors really want the information that is found in the narrative part of the office visit notes or in the interpretation part of radiology or pathology reports. This is where the important information is. I have tried to use the patient portals to have access to my records and to manage my health, but when you see a lot of doctors who work in different health systems, you end up with a lot of separate portals that don't have the ability to connect to each other. I'm up to at least 23 different patient portals, all with completely different website addresses, usernames, and passwords. And they all have 23 different versions of my medical information. Most of them have missing or incorrect information. Only one of the 23 actually provides me with my office visit notes or radiology results, and very few of them even have lab results. None of them allow me to edit the information. When they do let me see the details, it does help because I can download the note or report myself, and I don't have to deal with all of those record request forms to get the documents. So to help with this, I started making a pre-visit summary before my visits. I keep a Google Doc and make a copy before visits. I add any visits that I have had with other doctors and copy their plan into the document. I add the questions and things that I want to talk to them about and write down the reason I am visiting them. I include my medical information, but I also summarize my recent visits and procedures so that it is easier to read than the really long medical records. I can also add in details from my perspective, such as how my pain levels are and other relevant information. I then attach the medical records that I have gathered from the record request process. I always include a cover page to make sure that they know that I want it to be reviewed ahead of time so that I can be sure that they have everything needed. Also, because I have a rare disease, sometimes I ask questions that need to be researched ahead of time. I start the report with basic information and the reason I am coming in for an appointment. Next, I have the items that I want to discuss at the visit. I use this to make sure that I don't leave before the things that I want to accomplish are done. It also keeps the visit more focused as the doctor knows how many topics there are. I then summarize the recent visits I have had so that I can share the relevant data. I mainly just copy and paste this part from part of the note where they type their plan. Next, I include my recent and ongoing diagnoses, allergies, and current medications, and I note which ones I want to refill for. Then I include any recent procedures or tests, functional issues and pain status, and finally a list of all of my doctors so that they can easily contact them if they need to discuss my care. I then attach the actual records that I summarized in the earlier part. Here are some examples of the records that I include at the end. What started out as an experiment has worked pretty well. So far, I have sent the report to all 12 doctors in ER and in urgent care, and I have modified it as I have gone on to make it work better for me and my doctors. My doctors and nurses love it. They ask how I did it, and I tell them I do it manually in a Google Doc. They say that they wish every single patient had this. My visits are so much more productive and effective when they have the information they need. It reduces my stress of trying to remember everything. It has also prevented me from having that feeling that I get when I'm on the way home from the visits where I forgot to ask something important. This is problematic when you forget something. It means that you have to start the long phone tag process with the office, which is never as good as the in-person conversation. My ask of you today is to make this process a lot simpler. I don't want to spend time requesting and summarizing records. This burden should not be put on the patient. Technology should be able to do this for me. Create my pre-visit summary in an automated way. I would love to have FHIR pull the relevant information and let me add my issues to discuss at the visit and any other notes. Create triggers to send copies of records using FHIR to patients and the providers the patient wants you to send them to, so that these out-of-date forms don't have to be filled out and faxed around so much. If you work on an app that accepts FHIR messages, create a workflow that doctors and nurses like. I'm asking you to help make every patient's lives just a little bit easier.
Here we are learning how to do these transitions. So Morgan, that was terrific. It's hard for me to believe you're still in college, right? You're an undergraduate.
Well, I actually just graduated last month in May, but
that's close
really
enough.
close, yes.
Wow. And so is there any end to this insight, or is this going to be what the rest of your life is like until you have a nonprofit to trying to find a cure, right?
I mean, I really, really hope that this isn't, that I don't have this issue for the rest of my life, but, and hopefully if the technology can be improved sometime soon, I would really appreciate that. And I know a lot of patients would. So I'm hopeful, but right now, not so much.
So I personally, we didn't get any questions from the judges about your presentation, but I'll ask, are you available to consult, to be hired by companies working on these things?
I am, yes, especially now that I just graduated. But yeah, no, I've done a lot of consulting work over the past few years. I know you mentioned earlier that I kind of got into all of this when I was 15. So I've been doing some consulting here and there and speaking gigs at different conferences across the country. But yeah, this is like something I'm really passionate about. So I'm definitely open and willing to talk to different companies and consult.
Well, and the point that I want to make, and then we can move on because we're at the end of our time, but so often companies, especially in healthcare, will think, well, patients should be glad that we even listen to them. I mean, isn't that what Osler said? Well, but on the other hand, when you've got somebody who has so thoroughly prototyped exactly what the solution needs to do, there's some economic value in that. So, okay, great. So thank you very much and for being willing to go first. And for those who don't know, turns out Morgan's been sick the past week and she put that together even in the middle of all of that, because that's what you get when you have actual sick people involved in conferences. Yeah, so we have to figure out how to do silent applause, right? So, okay, good. So I'll turn it back to you. It's time for our break, right? Transition to the next session.
Unmute. Yes, let's transition. Thank you, Dave. Thank you, Morgan, too, and thanks, Don. I'm happy the technology worked, and we're here. We got another 5 minutes for a bio break, grab a drink or whatever, because at 8 o'clock here, but that's 2 o'clock Eastern, we'll continue with the first block of 4 or 5 sessions. So look at your agenda to pick the next one, grab a drink, and see you later.